Functional constipation. Normally, stool should be soft, normal caliber, and easy to pass. Before going further about functional constipation, let's see about typical frequency of a normal bowel movement in children. Typical frequency varies with age. In infants pass 3 to 5 stools per day, up to 1 stool per week. This variation is normal if the stool is soft in consistency. Between 1 to 4 years, they pass 2 to 3 times per day, and above 4 years, children pass 3 times per day up to 3 times per week. When we came to epidemiology, constipation is a very common pediatric problem. Approximately 3% of all visits to pediatricians are due to constipation. The prevalence is equal between both genders. In more than 95% of cases, functional constipation is a source of constipation in healthy children more than 1 year of age. Normal stooling behavior in infants under 6 months might include straining, turning red, crying for 5 to 10 minutes as a result of uncoordinated defecation before passing a stool. This is called infant dyschezia, and it is normal as long as the stool is soft, and it will disappear by itself after 9 months of age. So let's define functional constipation. Functional constipation is a delay or difficulty in defecation that is present for 1 month or more and sufficient to cause excessive straining and or pain. The Rome-4 criteria are the international standard for defining functional constipation. This Rome-4 criteria is divided into 2 subgroups: children more than 4 years and the children less than 4 years. When we see Rome-4 definition in infants and toddlers up to 4 years, at least 2 of the following present for at least 1 month: 2 or fewer defecation per week, history of excessive stool retention, history of painful or hard bowel movement, history of large diameter stools, and the presence of large fecal mass in the rectum. In toilet-trained children, in infants and toddlers, the following additional criteria might be used: at least 1 episode per week of incontinency, which is called retentive encopresis after the acquisition of toilet skills, and history of large diameter stools that might obstruct the toilet. In more than 4 years, at least 2 of the following present at least 1 per week for at least 1 month: 2 or fewer defecation in the toilet per week, at least 1 episode of fecal incontinency per week or encopresis, history of retentive posturing or excessive volitional stool retention, history of painful or hard bowel movement, presence of a large fecal mass in the rectum, and history of large diameter stool that might obstruct the toilet. The symptoms cannot be fully explained by another medical conditions. This is Rome-4 criteria for functional constipation. When we see the pathophysiology of functional constipation is usually triggered by the urge to avoid defecation due to pain or social reasons. Withholding causes colonic mucus to absorb more water, making the stool more difficult to pass. As stool retention continues, the rectum becomes more dilated, and the fecal incontinency or encopresis and the loss of the urge to defecate ensues. It is a vicious cycle: painful defecation, voluntary withholding, then stasis with reabsorption of fluid, then more pain. This becomes a vicious cycle that is difficult to stop. There are common times for kids to develop constipation. Those include transition from breast milk to formula, starting solid foods, potty training or toilet training, starting school because of reluctance to use unfamiliar bathroom. Assessment and the diagnosis of functional constipation starts with patient history. In neonates, determine whether meconium has passed at all, and if so, when. For older children and infants, history should note onset and duration of constipation, frequency and the consistency of stools, and the timing of symptoms, whether they began after a specific event, such as introduction of certain foods or stressors that could lead to stool retention. Important associated symptoms include swelling or stool incontinency, discomfort during defecation and the bleed on or in the stool. The composition of the diet, especially the amount of fluids and the fiber, should be asked. On physical examination, most of the time it will be normal. However, we should have to rule out evidence of organic cause. Check gross parameters. Evidence of failure to thrive might indicate an organic cause for the constipation. Examine the abdomen. Evaluate for a mass in the lower left or suprapubic areas representing a fecal mass. And also, depending on the chronicity of the constipation, there might be some abdominal distension present. You should have to also see the perianal area. You should have to take note of anal position and the skin tags or fissures. Lumbosacral region should be noted for any dimple, tuft of hair, gluteal cleft to evaluate for signs of neural tube defects. Let's see some red flags that shows functional constipation is a less probable cause for the constipation. Those includes no stool in the first 48 hours of life, which might show a ganglionic megacolon, signs of constipation less than 1 month old, narrow diameter stool, which suggests anal atresia, anatomic abnormalities such as on the back and the coccyx and the position of the anus, new onset weakness in the legs and the locomotor delay, and also abdominal distension with bilious vomiting. If those cases are there, functional constipation is less likely. There is organic cause for the problem. Therapy for functional constipation and encopresis includes patient education, relief of impaction, and the softening of the stool. If an impaction is present on the initial physical examination, an enema is usually required to clear the impaction, while stool softeners are started as a maintenance medication. This impaction is for children who present with a fecal impaction during examination. There are different drugs that is used for this impaction, such as polyethylene glycol, milk of magnesia, mineral oil, and the lactulose or sorbitol. And after disinfection, the next is maintenance phase. After successful disinfection, the child should begin a daily maintenance regimen with a goal of 1 to 2 soft stools per day. We achieve this by different drugs such as milk of magnesia, mineral oil, lactulose, polyethyl glycol, and also for short-term treatment, we can use glycerin enemas and the bisacodyl suppositories. If there is no bowel movement in 2 to 3 days, try enema or increase the laxative dose. If fecal incontinence reoccurs, return to the disimpaction phase. We should have to ensure intake of recommended dietary fibers, and we may try fiber supplement. However, avoid if fecal impaction and the stool withholding are not resolved. In that case, fiber supplements can make impaction worse. The other issue is about behavioral modification. Schedule time for toileting about 5 to 10 minutes after meals, especially breakfast and dinner. Reward systems such as stickers for when child has a bowel movement and the monitoring of stool patterns. Begin weaning laxatives once a child has regular stools and no episodes of acute constipation or fecal incontinence for 2 to 6 months. If reoccurrence occurs once weaning has started, it is important to have a rescue plan such as increasing the maintenance dose or enema use. And the discontinuation of the maintenance phase may take months to years. This is all about functional constipation. Thanks for watching.